of that, what are you guys seeing in terms of some of the more common issues as patients get discharged, particularly those who are, let's start maybe Dr. Rich, with those who are in the intensive care unit. What are you seeing in terms of those patients who are heading home post-intensive care for long times?
Myself here, yeah. So, as I mentioned, I'm primarily on the outpatient side. I have plenty of colleagues. We're kind of bummed Dr. Ridgway wasn't able to make it here because he's kind of on the front lines here. But from what I've heard, there's been a mixed phenotype of how these patients are presenting. Let's just be honest, this is a wild virus. It's affecting multiple different systems in patients with underlying issues already. So we're even hearing that there may be some Guillain-Barré-like presentations in a certain sense, where we're seeing these like almost profound, neuromuscular weakness. There are also obviously the pulmonary concerns, right? So patients are very short of breath because of some of the profound inflammatory changes in the lungs, which may lead to other long-term fibrosis and other issues. The big concern is the stabilized patients who have the most severe symptoms. They go on a mechanical ventilator, positive pressure ventilation, which if you're on a ventilator for longer periods of time, a lot of issues can happen to you. It builds up secretions because of the positive air pressure that goes in the lungs, which prevents mucus flow. So you can have issue of secretion build up. You can have barotrauma in the lungs, already on something that's already had all these inflammatory changes. Yeah. The other side is you see within the first 18 hours in many patients a condition we call ventilatory-induced diaphragm dysfunction, or VIDD, which causes profound and rapid atrophy and weakness of the respiratory muscles. And then you may also see changes, in the skeletal muscles. So profound weakness, maybe some issues with weaning from the ventilators. Again, because you look at the case mortality rate for this population, I think like 50% of them are obese, or the statistic, but a high number of them.
High number.
And those patients in general are very difficult to wean from a ventilator. It's a bit of an operative risk. And then, they're a large number of them are on ventilators. So it's a bit of with an acute illness. So we're seeing, it's been a mixed bag, but the pulmonary concerns, the weakness, and then we're finding now, there may be even some neurological changes. And then, of course, obviously the clotting, which has kind of gained some recent attention, the hypercoagulable state. We're even thinking maybe microvascular changes, myocarditis. It's wild virus for sure.
And so that means, for a lot of us, when we hear people are recovered, we assume they're back to their normal. And it sounds like no.
Yeah, it's going to be
in your head.
Yeah, I know. I talked about some paper we had published just recently in the American Journal of Medicine, and we have a few more coming out. But yeah, even if we get past we address the physical body structure impairments these patients sustain. Yeah. Right? Even if we remove the underlying pre-existing conditions they had, which a lot of them have.
Right.
To unpack and process being hooked up to a ventilator in an ICU, close to death, it's a harrowing experience for most people, and it's a hard thing to process. Notwithstanding that you may be in an ICU that, you may not have normal circadian rhythms because you maybe don't have sunlight, right?
Right.
So the ICU delirium, Dr. Jason will talk a lot about this himself, compared to research, the post-ICU syndrome that patients get even without COVID. So even if you get past the physical manifestations, the affective domain, affective domain are profound.
So Dr. Jason, what is that? What is post-ICU syndrome?
Yeah, it's a good question. It's something that's definitely been in the news more. I know I've seen articles in the Washington Post and NPR. It's really it's a sequela of symptoms. It's physical, cognitive, so the way you think, and emotional dysfunction that kind of persists after the physiological damage has kind of resolved. So once your infection has resolved, your sepsis has resolved, and the medical issues that kind of brought you into the ICU, there are these lingering issues. And they last for 6, 12, months or more. I mean, there's papers out there that say 5 years later, even healthy younger people are at 70% of their maximal exercise capacity compared to healthy, normal adults. So it certainly is a challenge. And I think there's another complication with COVID from a policy standpoint that's making it even worse, is these patients have prolonged ICU stays for all of the reasons that Dr. Severin mentioned, but then there's nowhere for them to go after hospitalization. Skilled nursing facilities aren't taking them without 2 negative tests, and often. So it becomes challenging to place patients. So they're in the hospital for longer, locked in a room because they're still infectious, not receiving therapy in many cases to preserve PPE. The deconditioning becomes an issue. So, we're iatrogenically increasing the deficits that they have, and they often don't have access to rehabilitation after discharge either, because either home care is not available or can't safely handle these patients. Or the patients are just too scared to have people coming into their house and reinfecting other members of their family. So, valid fears that I think really add challenge from a policy standpoint, because we just don't have the post-acute care infrastructure ready to flatten the disability curve that really is starting to manifest after the infection curve kind of subsides.
And that's a major thing. Yes, Dr. Rich.
Do that too, and I know Dr. Jason will, I know Jason personally, so I'll call him Dr. Jason. So, and Monique too. So, these were issues even prior to this, to the handoff. And Jason's written quite a few elegant papers on this. That this is a big problem already.
Yeah.
All this is just hopefully that we use this situation as a learning point, because this was a problem even before.
So, Dr. Jason, if you were in control of making the policy, what would you do differently here? Because certainly COVID-19 isn't going away next week or next month. This is going to be around for the immediate future, at least until we have a truly effective and widely distributed vaccine and effective treatments. So what do we do in the meantime? Because it does not sound like this is adequate, sending people at home, particularly if they don't have caregivers and if they're limited in terms of how many physical therapists are available to them. So what would you do, and what can those who are listening advocate for when they talk to their policymakers, or are in their town halls, or the elections are coming around and they're asked questions? What can they ask about this?
Yeah, it's a great question. And I think one of the things that I've really given a lot of thought to and pushed, and Dr. Grabowski from Harvard Med School, who's a post-acute care researcher, has also pushed something similar, is having rehabilitation at home model, where you can provide more intensive rehabilitation, be reimbursed at a much higher level, similar to a skilled nursing facility, but provide more intensive care at home. Our current home care infrastructure specifically defines the needs as intermittent, need for nursing and physical therapy care. So there's actually a cap on the amount of hours you can provide care to patients at home, which I think for these patients is really, challenging. And if we could put, many of these CNAs that are maybe out of work from long-term care organizations, or out of work from other places where there's a high infection rate, we could actually, we could redistribute staff from outpatient physical therapy clinics and from other places that are being underutilized right now, and have COVID-specific rehab at home, or COVID-specific outpatient facilities that we could provide all the necessary care in one place and really preserve PPE to the greatest extent possible.